Welcome, guys. It's been a while since I did a YouTube video, and who better to go back to a YouTube video, to my usual YouTube videos, other than Dr. Kristina Sule, our cosmetic gynecologist. She's back. So I'm sure you guys are excited to have her.
Thank you for having me.
You're
Thank you
welcome.
so much.
And on set today, we have two gentlemen. We have Dr. Eric Hungu, an
breast surgeon.
Just a breast surgeon.
Breast surgeon. Breast surgeon.
Nikimisiwa oncoplast something. On set we have two gentlemen. We have Dr. Eric Hungu, breast surgeon.
Yes.
Welcome. And we have Dr. Andrew Odhiambo, a medical oncologist. Welcome on set.
Thank you very much.
It's a pleasure to be here.
Welcome. So I'll allow the doctors to give a brief introduction of themselves. We'll start with Dr. Sule. Ladies first. Dr. Eric.
Hi, everyone. My name is Dr. Kristina Sule, and I'm a consultant obstetrician and a general and cosmetic gynecologist. Thank you so much for having me once again.
Welcome, Dr. Eric. She's actually the one who made me do this YouTube video. Yes.
Welcome, viewers. My name is Dr. Andrew Odhiambo. I'm a medical oncologist practicing at the Nairobi Hospital, and I'm also happy to be here to share knowledge about cancer.
And my name is Dr. Eric Hungu. I'm a general and breast surgeon in Nairobi. Pleasure to be here.
So we are all aware that October is Breast Cancer Awareness Month, and today we're going to talk about cancer. I know it's a very sensitive and heavy topic, guys, so in case anyone gets offended, we apologize in advance, but it's a topic that is sort of nowadays people are able to talk about it. I know there's a lot of stigma around it. No one ever thinks it's going to be them until the day it is you.
Yeah.
And we can all agree that when you're told, you're given a diagnosis that you have cancer, your next question is, it's a death sentence. Can I see my lawyer? Can I see, they usually there's panic mode. And so today we want to talk about that. If I walked into your office, Dr. And definitely people come to your office because they're on panic mode, like I said. If I walk into your office and say, Dr. I have cancer,
Then what?
what options? Then what, Dr.
So I think cancer is a pertinent issue now. It's a conversation that we should be having more often. And I think because October, which is normally known for Breast Cancer Awareness Month, there's usually a lot of push to create awareness against cancer. There's a famous writer called Anthony Del Monte who quoted once and said, cancer does not have a face until it's yours or somebody you know. So patients normally walk into my clinic and they come with results and they've been told, you have cancer, go and see the oncologist. And they're usually very scared. The first thing they ask you is, what is the stage? Am I going to survive? What is the prognosis? When really we haven't even gotten down to knowing how far this cancer has gone, but people are usually very scared. And the fear is mostly because of ignorance and just lack of knowledge. So if people knew more about cancer, then people would be less scared. I wish cancer could be taught in primary school, in secondary school, the way we are taught about malaria and other things. Yeah. Cancer should also be taught to small kids so that they know you can get high blood pressure, you can get cholesterol problems, you can get kidney problems, but you can also get something called cancer. And this is what it is. And in case you get it, then this is what you need to do.
In terms of people thinking, when you hear the word cancer, book a flight, what would be your comments? Do you reassure people that we definitely do have competent doctors in this country?
So most of the time, patients who want to go overseas for treatment, India is the best example, but it doesn't mean that India is the only country that treats cancers. People go to South Africa, to the UK, to the US. There's a perception that maybe the local doctors don't have enough knowledge, or people use personal experiences. They will say, oh, my neighbor went to India and was treated and got cured. And then when they put on the TV and watch Kenyan news, it's just bad stories and bad stories. So it's many factors coming into play. But in Kenya right now, say apart from, in fact, recently bone marrow transplants have started in Nairobi. So except for very specialized surgeries, and he can tell you, most of the cancers can be treated locally, unless maybe you're going for a clinical trial or something. Most of our specialists are actually trained in the US, in the UK, even in India. In fact, we have many Indian doctors in Kenya, but people still feel like, no, I have to go to India. You don't have to go to India. You can be treated here. It costs cheaper to be treated here for most cancers. When families are around, when people are around, it's better. The food in India is hard to eat. So you can't
Yes, that's
you
true.
can't be there. Like some of my patients tell me, I have to carry tea leaves and things
Yes.
and make githeri and whatnot. So, I mean, as a patient, you're entitled to be treated anywhere in the world that you want to because it's your body, but just have the right information. Many patients who go overseas for treatment, they don't know that what they're actually going to get is available in Kenya. I'll give you an example. It could be a small village, maybe in your shags, and then there was a lady who went to India, who got treated and came back and went to church and spoke, and everybody got converted. So then other neighbor gets cancer, and it's like, Mama Shiro went to India. So they just start getting passports and things, and they don't know that if they just came to Nairobi, they would have gotten exactly what they're going to get overseas, exactly. And then they come back with all these medicines and they're like, I wish we knew, maybe nobody told us. So I think also, the health ministry probably should be in charge of this and have probably a website or somewhere where patients can go and get the correct information. That you really don't have to fly and stress yourself so much to go and get treatment that's available here. If we doctors, we know that there's a certain test or a certain scan or technology that we don't have that will help you. In fact, we will even push you, like, get on a plane and go wherever you can go and get this treatment and then come back.
What are my options if I have cancer? Start from there. What options do I have? Because I know the first thing that comes to people's mind is chemotherapy, radiation. I'm at what stage?
So allow me to use breast cancer as an example because we are in the month. So as an oncologist, I don't work alone in treating cancer. We work with the surgeon, with the nurses. It's a big team. So when I see you on day one and you've got your report that confirms it's cancer, we go through a process of helping you to understand the diagnosis. We help you to know the stage of the cancer. So you need to do some scans for us to know that, so that we can then sit down and say, you have stage 1 breast cancer. We have a meeting, we discuss, then we say, for you, you can go straight for surgery. And maybe surgery alone is enough. On the flip side, if you've got stage 3 breast cancer, we'll sit down, have a meeting, look at your reports, look at your scans, and then we'll say, no, your cancer is a bit too big. You need to do chemo first, make it smaller, and then go for surgery. And then maybe later, radiotherapy. So what I'm trying to say is there's no one shoe that fits all. We have to have a lot of consultation before we decide how your journey is going to be. And then we just take you through that journey. And everybody's journey is different. Breast cancer is not all treated the same. So you can't say, me, I'm taking this medicine. Why are you not taking it? No, the cancers are not the same. Okay?
It's unique to everyone.
Everybody has a different journey. So the options are many. Myself, I specialize mainly in chemotherapy. So by default, I'll be treating breast cancer patients who are in the later stages. Most of them are actually having stage 4 breast cancer, and some of them having stage 3 breast cancer. And we use a lot of chemotherapy to treat these patients. When they come to see me, everybody is so afraid. Like they hear chemo, they hear like I'm going to burn, my veins are going to burn, my skin is going to change, and lots of nasty things will happen to you. But I'd say over the last 2 decades, we have become better and more efficient at delivering chemotherapy, because we have many medicines that we use to make the chemotherapy more gentle on the body, so that you're actually able to go through your chemo without significant side effects. I have patients who are on chemo and they are working every day. Some of them are nurses, teachers, he'll tell you, and they come for chemo, and the next day they're going to work. Teachers, the next day they're going to work. So they ask me, will I be weak? Will I feel down? Sometimes it's in the mind, okay? If you're positive and if you talk to your doctor and tell him what you're going through, then I can help you to minimize your side effects. And then you just finish and wonder what the entire fast was all about. So it makes a very big difference for the patients. Their tumors are able to become smaller so that then the surgeons can take them out easily. And then you can actually very easily get cured from breast cancer. You just need to follow the pathway that the doctors have told you, keep to your appointments, take your medications the way we say, and most of the time we can get you sorted out.
Okay. Thank you, Dr. Ari. So I hope as we are continuing with this conversation, someone out there who's listening, yes, fear will be there, like Dr. Ari has mentioned. But remember, they are competent doctors. They are really out there to give you a wholesome treatment, an all-round treatment, tailor-make it specifically to you. Like they've mentioned, it manifests differently to everyone. And I think one of the main things that sometimes when I started, it's information overload. When there are too much information, too many people, too many opinions, and it is always very important to trust your team of doctors because they have your best interests at heart. And like the doctor mentioned, it is okay. You can ask the questions. You can research, and the doctors are here. They are quite patient. They are very patient. They are very patient. Okay, Dr. Ari, thank you. Are there any newer treatments that don't involve chemotherapy or radiation?
That's a very nice question you've asked, because sometimes patients come and ask me, doctor, we have been Googling and we've seen there's something called immunotherapy. And we want that one because we don't want chemotherapy because they're afraid of it. So in short, yes, there are newer treatments. I think since 2016 up to now, we've got very many new drugs to treat cancer, different cancers. Some cancers we still use chemo up to now alone, but some of the other cancers, like say lung cancer, for example, we have newer treatments. Some of them could be in tablet form, which are easy to take and you just go on with your life. And then the other one is called immunotherapy. So immunotherapy works differently from chemo. So chemo, we put it in your body and then it goes and kills the cancer cells directly. And by that, it can also cause damage to normal cells. But immunotherapy is different in that once we give it to you, it goes and reactivates your immune system to fight the cancer, okay? So think of it like in your house, you've got askaris guarding you, okay? And then when the thief comes who is cancer, they throw in a smoke bomb and the askaris go to sleep. So then cancer can enter and cause problems and so on and so forth. So what immunotherapy does is it comes to wake up the sleeping askari. So the askari wakes up and starts beating the cancer out of the body. Yeah, so when it works very well. These newer treatments also are expensive, so it's very difficult for many Kenyans, actually many people, to afford it. Even in Europe, I have colleagues who are telling me they can't afford the medicine. We hope that the price will come down, and so that many other Kenyans can use it. But I can confirm that we do have these treatments available in Nairobi, in Eldoret, in Mombasa. They are all there. You don't have to go anywhere to get them. We can bring them to you, and we've been using them since 2017. And if they work very well.
A question many women wanted to ask is, if you have stage 4 breast cancer, will you be able to survive? I know it's a tough question.
Previously, before we got these new medicines, the survival was very short. I mean, people would last maybe just under a year. But now with all this modern medication, we have learned how to treat stage 4 breast cancer like a chronic disease, like you have high blood pressure or you have diabetes, so long as you are taking medicines every day. And there are women out there in Nairobi who have been taking medicine for 7 years with stage 4 breast cancer, and you can't even tell. One of the ladies who works in my bank just told me, oh yeah, I've been on this medicine since 2016. I'm like, what? Yes, she has stage 4 breast cancer, but you can't see it, you can't feel it. She comes to work every day, she drives, she goes to church, and she's alive because of these modern medicines that we have. Yes, they could be expensive, but we have them, and NHIF is helping to pay for them. So it's not a gloomy situation for everyone. There are some who will be more unwell than others and not survive long, but some of them could. You can't know that yourself in your own sitting room and make your judgment yourself. You have to come to us. We'll go through your reports. We'll do all the necessary tests, and then we can tell you, for you, you're a good candidate for this new medicine. Take this medicine and everything will be okay. And most of the time, things become okay. You could die from something else. I mean, we are all going to end up there.
Yes. Yeah.
But if I can give you 5, 6, 7 years that you didn't have, that is definitely better than nothing.
Okay. Okay. Like I mentioned earlier, I was just telling all the doctors, they call her doctari. I was telling all the doctors that this is a free consult. Not only you watching, learning, I'm also learning. It's a free consult, and thank you so much for taking your time, because this is most of the time we suffer from lack of information. So, Dr. Hungu,
Yes.
I will go straight into it. People have warmed up with Dr. Odhiambo.
Yeah.
So the breast surgeon, I asked earlier just to confirm, you're not a plastic surgeon.
I'm not a plastic surgeon.
Okay.
But I do work with plastic surgeons.
Work with plastic surgeons in what way?
So like Andrew said, it's usually teamwork. So it's like what we call it in medical language is a multidisciplinary team. Yeah. So once we've made a decision, we've made a treatment plan, and the treatment plan takes into consideration also what the patient wants. If they want some reconstruction, then we go in with a plastic surgeon, because the reconstructive bit is a little bit more technical.
Okay.
So my bit is treating the cancer, so oncological bit of the treatment.
Okay.
Although part of my training did involve the reconstruction, but if I have the expert in the field, I'd rather let them do their job. Yeah.
Okay. Is if I have breast cancer, and definitely the first question is, will I live? Please answer the question and the options. Second question, especially for us women, is, will I lose my breasts?
Will I look nice?
Will I lose my breast? How will I look after that? And it's a valid question. I know people like, you've survived cancer, you're alive. Why are you worried about how you will look? But at the end of the day, it's about, we talked about wholesomeness. And it's also about, if I've survived this, I also want to live my life fully. And there are many options out there, but I'd like to start with, is mastectomy the only option to breast cancer treatment?
No, it's not. Like Andrew said, every person walks their own different journey. So it depends on the stage that someone comes to us with a breast cancer. So that there are different stages based on the local disease. That's the disease in the breast.
Okay.
So sometimes you find someone who has disease that you don't feel. You only see it on imaging, like on a mammogram. So we call that a screen-detected disease. So if you have that, and it's not widespread, it's only localized to a certain area of the breast, then there are options of what we call breast conservation surgery. So that means we go and, if it's screen detected, we need to tag that area that has the tumor. And then when you are in theater, there are techniques, there are methods we use to locate where that tumor is exactly. So we remove that bit. And then depending on the size of the breast, sometimes we don't even need to do we call it volume replacement, so that if you remove a significant chunk of tissue, you can replace with more tissue from other bits of your body. Yeah. So if you have a big breast, which fortunately most of the African ladies do have, so if it's a small tumor, you can get away without having to do a tissue flap. And then there are those ones who come with what we call a locally advanced disease. So that means you are not able to operate initially. So then first it starts with him. He gives chemotherapy, shrinks the tumor, and then depending on the response, we might opt to go for a mastectomy. Now, mastectomy, there are different types. There's a traditional mastectomy where we remove the whole breast and the skin so that the chest is left flat. But then there's also some more modern types of mastectomy Again, depending on the tumor response to chemo and the tumor location. So you can have what we call a skin sparing mastectomy. So in a skin sparing mastectomy, you remove the nipple and a bit of the skin around the nipple, and then through that small incision, you can actually get the rest of the breast tissue out, and then you can do a reconstruction. Then there's also a nipple sparing mastectomy, so that if the tumor is a bit farther away from the nipple, you're actually able to spare the whole nipple, the whole skin. So all you're doing is basically like lifting up the skin envelope, removing the breast tissue, and then now you do a reconstruction, of which there are various types of reconstruction.
There are various types of reconstruction.
Yeah.
Okay. If you've reached a stage where a patient is ready for a breast reconstruction surgery, and definitely, obviously, consulted the team of doctors, like you say, we want a team of doctors, multidisciplinary.
Yes.
What are the options in terms of breast reconstruction? What options are there?
Okay, so we can talk about mainly two types of breast reconstruction. So one is implant-based, and then there's, to use the technical bit, we call it autologous. So that means we're using your own body tissues to sort of make a flap, to replace the tissue that we remove. So both are locally available. We give patients all the options depending on your particular disease presentation. So when we talk about the autologous, using your own body tissues, there are several types of tissue that we can use. So the most common that we use locally, we can combine sort of like a tummy tuck. So we get tissue from your tummy, the muscle, the skin, and a bit of the subcutaneous tissue. And we can either lift it up and come and implant it there. So that one we call it a free flap. So we have, it's a little bit more technically challenging. It takes longer in theater. It can go up to 8 to 10 hours.
It's long.
Yeah, for one surgery. But then there's a variation of that where we don't lift it up and transplant it or implant it. We just rotate the muscle on its blood supply, because for the flap to survive, it needs to have its own blood supply. If there's no blood supply, it dies. Yeah. So that's one type. The other type, we can get muscle from the back, and then we rotate it to the breast, the area where we remove the tissue, or the whole breast. So the thing that people need to know is that when we do that type of reconstruction, you're going to be recovering from two scars. So you'll have a scar down there, scar at the breast. The other type of reconstruction that's available is the implant-based. Now, if we do implant-based, usually we do like a two-stage sort of procedure. So at initial surgery, at mastectomy, we can put a temporary implant. We call it an expander. So that means at the site, we bury the expander. Depending on whether it's a skin sparing or a nipple sparing mastectomy, we put in the expander. And then you'll have to be coming to the clinic serially, like every 1 or 2 weeks, because we need to expand that temporary implant until we get to the desired volume. And then when you get to the desired volume, you can go for radiotherapy. Because the thing about getting radiotherapy is that you're being exposed to that radiation. It can cause the operated area to contract and to shrink. And that's one of the downsides of doing like an immediate reconstruction with your own body tissues. But again, people respond differently to the same sort of treatments. So once you've done your radiotherapy, then we give you about 6 months for the skin to recover, for the tissues to recover. And then you'd have to go back to theater for the second stage, where now we remove that temporary implant, and then now we put the permanent implant, which is usually the silicone implant.
Okay.
Yeah.
Okay.
So can I ask you whether the husbands have a say?
No.
Actually,
Maybe they do.
Actually,
Do they?
They should.
in our setup, it's a conversation.
It's a conversation.
Yeah.
Kristina, this is your area of sexuality. The breast is a sexual organ,
Yeah,
isn't it?
the sensitivity still be there.
Yeah, it's not just a breastfeeding
So in his
organ.
mind,
It
he's
is a
like,
sexual organ.
now this is
Yes.
too plastic.
Yeah, I personally advocate for partner involvement almost in all stages of any treatment, because this partner at the end of the day is not just a sexual partner, but it's also a support system for this person. So I think their decision should count.
It's
Yeah.
true. So like when the patients come to my office, what I usually tell them, you actually raise this issue when you have the diagnosis, people go into panic mode. Like, I'm going to die if you don't treat this now. So I usually try to tell them, in medicine, we have different categories of diseases, well, sort of broadly. So you can have an emergency. So breast cancer is not an emergency. We have time to do all the appropriate tests, like Andrew mentioned, come up with a definitive diagnosis and your disease biology, and then we make a treatment plan. So when we're talking about the surgical options, I give them all these options, and I usually encourage them to come with their significant other. And sometimes I even tell them, come with the rest of your family. Sometimes in the office, Andrew knows, you have like 5-10 people in the office. Yeah. So you give them the options and tell them you don't have to make the decision now. Go think about it, especially you and your husband. I don't discourage Googling.
Yeah.
So you can go do your research. As long as when you get that information, come back to us. And we can go through the information you have, and I can tell you whether it's correct or it's wrong. And I can tell you what we have here locally and whether that option is good for you.
Okay.
Yeah. So coming to Andrew's question, the husbands do play a role in making that decision.
Okay.
Yeah.
And when it comes to, for example, if I've survived, and now we are at the stage of where I can do the breast reconstruction, and maybe I want to go a size up or a size down,
Upgrade.
an upgrade. Has it ever happened?
It's not very common. So what will happen, like I mentioned earlier, our local population happens to be quite well endowed. So you won't find most people saying they want to go a size up. Most of them actually want to go
Breast reduction.
a size lower.
Okay.
And the thing is, when you do surgery and reconstruction on one side, it's smaller in terms of volume. So we have to do a surgery on the other side just for symmetry. So on the other side, you can either do a lift or a reduction depending on the size you're starting with.
Can a patient have the treatment? Can I have the chemotherapy and at the same time have a breast reconstruction surgery? Is it advisable? Because sometimes a patient is, okay, can I have it concurrently? I want to go back to living my life and forget about this chapter. It's done. I'm starting a new chapter. I want to move on.
Yeah.
Can you have it? Is it advisable to have both procedures at the same time?
So no, it's not recommended. So the usual protocol is if it's one of those that needs to start with chemotherapy. So chemotherapy is quite a long process. I think, Andrew,
6 months.
6 months.
6 months?
Yeah. And if you're getting like 6 cycles or 8 cycles, in between cycles is about 3 weeks. So that gives your body some time to bounce back from the effect of the chemo, because chemotherapeutic drugs are very strong. So it's the same thing. Once you're done with the chemo, we give you about 4 weeks to recover from that. So we usually have a window period of about from week 4 to about week 12 where we can safely operate. So we try to operate closer to week 4 than to week 12. But that window period gives us some time so that if you're in a high volume center like in KNH and you have quite a number of patients, there's still some time for us to do the surgery safely.
Okay.
So to answer your question, we finish chemo, we give the body time to recover, then we go for reconstruction.
Because surgery is still surgery.
It is surgery, yeah.
Yes, your body needs time to recover.
Yes, and it's very intense on the body. Yeah, it's like it's major injury to the body.
Most women will ask, and they're pertinent questions, will my breast look the same? Will the sensation of, like you mentioned, the nipple, and we know it is important for our Sorry, what is the word?
Sexual
Sexuality.
Sexual life.
Oh, sexual
Yes, I know it is important for our healthy sexual life, and we said after this we want to live life in a wholesome way, fully in it and involved. So again, Dr. Will I have the natural look of my breasts the way they used to be before?
The short answer is no. It won't look as good as the original. Because of
Fair
course,
enough.
the original, I mean,
Yeah.
it's designed by God. But we try our best to recreate and reconstruct it to the best of our abilities. So again, different ladies have different breast profiles. So, and then we have the implants have different profiles. If we're using the body tissues, because it's normal, you're using your own muscle and your body tissues, there's a possibility that when you've moved it and then you go for radiotherapy, it can shrink. Then you can get some loss of muscle bulk, so it might sag a bit. So, but there are things we can do about that with the plastic surgeons. There's what we call lipomodeling. So you sort of go like for liposuction, and then we do the fat transfer now to the breast and sort of like try to get it look as nice as the original. But that's something that most people need to understand, that it will not look as good as the original, but it looks good.
It looks good. Okay. And as you've been talking, Dr. Ari, I've been just going through my mind, and I think it could be a series of, it's a journey. Even the breast reconstruction is a journey, because it could be a series of surgeries before we get to what is the best result for you.
That's true. So different people, different responses.
Okay.
Because again, your age, how your body tissues are, because we've done this, and then again, of course, with any surgery, there's always a possibility of some complications. Because if you get an infection, we have to treat that infection, and as we're treating the infection, the tissue might shrink. If it's an implant and you get an infection, we have to remove that implant and give the body time to recover, and then I'll do a delayed reconstruction. But we have had some patients who we've done the immediate reconstruction. It's just that I can't show you pictures, but when people come to the office, I can actually show pictures, but not showing the face. And some of them actually look really nice. Yeah. So it's something to consider. Yeah. It's something that's available. It's something that we can do.
Dr. Do patients worry about scarring? Because it's a question, scarring. That area where the reconstruction has been done, scarring, change of skin color, it will be a bit darker. How would it look? And look, when I remove clothes, for example, I did this surgery, or this diagnosis was before I met my partner, and now I've met someone, and they didn't know where I've come from. How would it look like? I think that is a fear most people have.
Yeah. So unfortunately, because of surgery and the nature of surgical treatment, you will always have a scar. The thing we try to do is manage the scar. So depending on the size of the breast and the technical expertise available, we can actually make a cut on the lower part of the breast. We usually call it the inframammary fold. So when you make a cut through there and you lift up the skin envelope, you can actually be able to access all that breast tissue and remove it. And then when you put the implant or your muscle, then it's well hidden. And then, so you'll always have a scar. We just try to manage the location of the scar and how the scar heals, depending on our surgical techniques. And then, of course, we try to manage any complications that might arise, because if you have complications, then the chances of the scar not turning out quite nicely are higher. And then, of course, also depends on the patient themselves and their biology, because there are people who are predisposed to getting big scars. We call them either keloids or hypertrophic scars. So we need to have that history with us as well, so that we can manage that potential outcome or potential complication.
Dr. Eric, if I would prefer, as a patient, instead of going for the implants or to have the tissue transfer, what if are there women who go for the external prosthetics?
Actually, so broadly, Okay, so as medics, we like to work with categories and
Okay.
classifications. So broadly, we can have two categories of ladies. There are those ones who come and they want us to do reconstruction. There are those ones who come and they're like, don't really care about reconstruction, just get the disease out. So for those ones, we have the option of doing the breast prosthesis, which is an external device and doesn't involve extra surgery. So when you go for the traditional mastectomy, you remove all the breast tissue, the skin is left flat. Then there are those special bras, the mastectomy bras, and then there's a prosthesis that you put inside the bra, between the bra and your skin, so that when you put on your clothes from the outside, no one can tell that you've had surgery. So it is cheaper. You don't have to get repeated exposure to anesthesia. So some people do opt to go for that upfront, and it is an option that's available locally.
Okay.
Yeah.
Okay. Like we mentioned earlier in the video, when you suspect you have cancer, you have a diagnosis that you have cancer, I think there's a lot of stigma around it. Actually, most people will attest to it. It's like a death sentence, and sometimes you will give up before even trying or consulting. What is your opinion on that?
So, cancer is not a death sentence. And especially you as the patient, you can't determine that probability. The doctor has to determine the probability for you. To be honest, there are some cancers that are deadly, meaning once we get the diagnosis and we are being very frank with you, you might not live too long. But then again, there are others which we can find them early and you can actually get cured and just continue with your life. But you hear the C word and then you just think of my funeral and this and that. So most of my new patients, I really take them through a lot of counseling, a lot of talking about it, owning the diagnosis, and understanding what the doctors are going to do for you. I have patients right now who are struggling to accept that they've been cured. Do you understand? The fear was so intense. The accepting was so intense. Now we've treated them, they've gotten cured. And we look at the scan and tell you, Shiro, your scan is clean. They don't believe it.
Cancer free.
They don't believe it because they just, people, sometimes my patients tell me, even when I go to the church, there are people look at me like they expected me to have already gone by now, pancreatic cancer 2 years later, and you're still alive. So not everybody with cancer has to die. People with heart disease die. People die from pneumonia. People die of road traffic accidents. People die of suicide.
People die in their sleep.
Everything is a death sentence in its own way, but
yes, it is.
treatment is there. Go to your doctor. Let your doctor advise you on what you need to do. Those bad ones, we know them, will counsel you appropriately. But especially for breast cancer in the early stages, it's relatively very easy to get you cured.
Okay.
Unless something supernatural is against you.
And actually, if I come to you and a team of doctors, like you mentioned, a team of doctors, and I say, I don't want to have surgery. If I have surgery, I will definitely die. Is that a valid, is that, even saying it, saying it, I'm not like you guys, saying it sounds ridiculous, I'm sorry. Just for me, it's really sad.
It's just that
it's sad.
Hard to answer that because
it's hard.
People have their own beliefs. So having surgery is not going to kill you. The whole aim of that surgery is to actually cure you. And what happens is that for cancer, for some cancers, in as much as you get chemotherapy and all the other things, mainstay of treatment is surgery. Yeah, but there are some, like Andrew will tell you, that surgery will not benefit, like the blood cancers and such. But for these solid cancers like breast cancer, surgery is a mainstay. So having the surgery is not going to kill the patient. It's actually beneficial. Yeah. And like we've said, we have reconstructive options. So the main aim first is to get rid of the disease. But secondary, we want you to look good and feel good about yourself. So the reconstruction options are there. Yeah.
Support groups also help. Yeah, you introduce your patients to somebody else who's done the same or gone through the same thing, so that they can see it's real. Like, you had surgery and you're okay, then I can be okay too. So eventually we get to convince most of them to go through surgery well, but it takes a lot of investing time, talking to the patient, encouraging them, counseling them. They will eventually agree. If they are good candidates for surgery, they usually agree.
Now, at Dr. Sule, they've mentioned about cancer treatment, the chemotherapy, the radiation, the mastectomy, the breast reconstruction. Again, it's a team of doctors. And here comes a lady or a patient who has questions of, I'm going through chemo, I'm going through radiation. Can I still have an active sexual life? And not only active, but can I still enjoy sex?